Dear colleagues and friends, happy World Hearing Day in 2022. I'm very glad to see so many participants in our webinar on auditory processing disorders, listening difficulties, and related challenges in school-aged children. And we have some really well-known, world-known speakers who have been gathered here to talk about this problem. Harvey Dillon, Susan Purdy, Joan Leung, Amelie Hesping, David Moore, Mridula Sharma. I'm very glad to share our contents with you. So, to introduce the problem, the WHO World Hearing Day 2026 focuses on the problem that hearing loss affects around 90 million children and adolescents aged 5 to 19 years, according to the Global Burden of Disease Study 2021. So globally, school-aged children with hearing loss often remain undiagnosed and unaddressed, especially in low-resource settings, according to the World Report on Hearing. There are a lot of known preventable and treatable causes of hearing loss, commonly otitis media with effusion or chronic suppurative otitis media, which still remain prevalent in children. If they left untreated, the hearing loss impacts speech, language, cognitive, and social development, often leading to poorer educational outcomes, reduced employment prospects, long-term economic disadvantages. However, another condition which is not yet under focus of WHO, but may have the same consequences, are auditory processing disorders and or other listening difficulties in children. They typically become apparent in school settings, and therefore we want to bring it on the table today. What are auditory processing disorders? They are circumscribed deficits in auditory information processing and perception, despite children have an intact peripheral hearing and at least average intelligence. They are listening difficulties due to neuronal dysfunction, which involve interconnected neural networks. The condition affects processes which operate in series and parallel along the auditory pathway and are involved in processing of both nonverbal and verbal auditory signals. Looking at the International Classification of Diseases in the ICD-10, there APD were still assigned to specific developmental disorders of speech and language, because many of the clinical symptoms are language related. In the ICD-11, this has been corrected. Now they are assigned to other specific disorders associated with hearing impairment, fortunately. Matching terms are auditory processing disorders or central auditory processing disorders. There are different prevalence numbers in children on general 2 to 3%, school-aged children 5 to 7%, and it is estimated that about 1/3 to the half of all children with learning difficulties have also some listening difficulties and listening processing disorders or difficulties. Boys are more affected than girls. they rarely occur in isolation. Usually, APD or listening difficulties in children are associated with other developmental disorders. Look at this figure, a little bit complicated, from a systematic review from De Witt et al. 2017. What you see here is a number of studies, and you see always the overlap where children involved in this systematic review show the same, show no differences if they have APD or they have another disorder. And the size of those circles amount to refer to the amount of children involved. And what you can see here, for example, for children with developmental language disorders, at that time still called specific language impairment, SLI, there was an overlap of 58, in 58 tests of or subtests involved. There were altogether 85 subtests or tests where children from 106 where children with APD did not significantly differ from the other disorder. And the italic numbers are those studies or those test results where they significantly separate from the other condition. And you see here the large overlap, and only the numbers in the circles here, the italic numbers in the circles, show the conditions where children with APD are significantly poorer than the other children with developmental language disorders, and they show weaker listening skills in 4 subtests. And here, APD versus dyslexia, only 1 subtest which also refers to weaker listening skills. Comparing children with ADHD, attention deficit hyperactivity disorder, there are only 2 subtests, and they show weaker abilities of those children in auditory and visual temporal ordering difficulties. And here, comparing APD with learning disorders, they show poorer results in spatial processing. Okay, this is very interesting. So we always have to have in mind all those other difficulties the children may face, which complicate each other. So symptoms, you see here, there is a large bunch of symptoms which may occur, but don't have to occur. Mostly the clinical symptoms there are language related, but not all of them. So we see a variety of clinical symptoms and see APD as an umbrella term with a couple of subtypes. So we will hear a lot about assessment of APD and listening difficulties today. Here I show you as an example the most discriminative German tests, but this applies also to other languages in general. Speech audiometry in quiet and noise. So if children perform much poorer in noise, that means they have a deficit in auditory selection, has a high discriminatory power. Phoneme discrimination tests, which test auditory sequencing, auditory memory span, phoneme identification and differentiation, dichotic speech or number tests, which test auditory separation, and they are mainly speech or language based. Recommended tests with non-speech stimuli have to be performed as well, such as psychoacoustic tests for minimal audible differences, for example, for sound duration, frequency, intensity, phase, and periodicity information, sound gap detection thresholds. What about intervention? We have 4 columns, I would say. Therapist-guided behavioral trainings, which based on the results of a test battery, providing an individualist auditory processing profile. The treatment includes 2 main components: auditory training, which targets the specific deficits, and individualized compensatory strategies. For example, if there are deficient abilities in auditory sequencing, the auditory training will be auditory memory and sequency training, of course, and the compensatory strategies may involve visual compensatory strategies. If there are deficits in reading and spelling, there's a training of phoneme-grapheme correspondence. The format could be an individual or group therapy at least once per week, or as an intensive training course, typically 20 to 30 sessions of 45 to 60 minutes each. Then another column of treatment is home-based training, using worksheets, games, computer programs, and structured instructions, in particular for improving auditory memory, which is often reduced in APD, and listening difficulties. Then, very important, signal-enhancing interventions, which improves the signal-to-noise ratios for children. Think about it. The noise in a classroom is equal at every place, but the teacher voice reduces by 3 decibel per meter distance. So what can help here? Curtains are very simple methods already to improve the signal-to-noise ratio. Acoustic sealants, acoustic panels, then assistive listening devices, also called remote microphone hearing systems, RMHS, formerly called FM systems, frequency modulation systems. Sound field systems, these are systems where all children in a classroom profit from. Questionable are low-gain hearing aids. We just perform a large study on this. And of course, a preferential classroom seating, but this does not apply to all children. And then the last column is linguistic, cognitive, metacognitive, and educational strategies involving specific interventions, for example, dichotic listening training, speech and noise training. So what is the problem which refers to the topic of our World Hearing Day, the classroom settings? The noise and reverberation significantly reduce speech perceptions in classrooms. There is a negative effect of background noise, reverberation time, and speaker listening distance. And this applies to children with hearing loss and to children with normal hearing. They all have the same or have difficulties due to those conditions. Furthermore, children with APD, ADHD, and learning disabilities and other conditions, Amelie will talk about this, often have normal hearing, but difficulties understanding speech in noise. The remote hearing microphone systems may particularly benefit children with speech and noise difficulties. And in my country, in Germany, they are only reimbursed by health insurances if this problem occurs. In 2002, the ANSI rules have regulated minimum acoustic standards for classrooms. They gave limits for background noise and reverberation, but many classrooms fail to meet the ANSI recommendations regarding noise and speech and noise ratio. And again, children with other subtypes of APD than difficulties of understanding speech and noise, and children with other listening difficulties could also profit from better speech and noise in noise ratio, such as remote microphone technology. We will hear a lot now about assessment and treatment and also neurological background of such children. And here I stop my introduction, and I'm very glad to introduce now Professor Harvey Dillon, who is a part-time professor at Macquarie University in Australia and has worked a lot in testing and treating children with APD and listening difficulties. He will speak about separating the causes of listening difficulties in children. Please, Harvey.
Thank you, Katrin. Yes, I'll be talking about the separation of the causes, not the remediation. So listening difficulties means just what it says. Somebody is having difficulty in listening, and that, of course, can have causes in the areas of hearing loss, which you might or might not see in the audiogram, auditory processing deficit, speech sound recognition deficit, meaning difficulty identifying individual speech sounds, a cognitive deficit, particularly memory or attention, and a language deficit. We all use language to fill in the gaps when there's an individual word we don't hear. What makes this a diabolical problem is that any one of these can cause problems in some of the other areas. Even worse, as Katrin mentioned, it often occurs with ADHD, but can occur without it, and often occurs with autism, but can also occur without that. We've gone about making up tests to help audiologists diagnose how much of the problem is falling in each of the areas. And I'm going to be showing you some results from clinics around the world. My uni has licensed tests to Sound Scouts, and I do a bit of consulting for Sound Scouts. That's a disclosure, but it's also something fantastic because it means that we can use the de-identified results to understand how common are the different types of problems in children arriving at clinics all around the world who are using the Sound Scouts portal. Those same 5 domains, hearing loss and auditory processing, speech sound deficits and cognitive deficits and language deficits, we can break them up into lots of subdomains and subdomains, but I don't have time for that tonight. Here's the model on which we base the battery of tests. We have a signal coming in. We have very complex auditory processing that analyzes the signal in lots of different ways. How well it does it depends on noise and reverb and things like that. If there are speech sounds, then those analysed signals get used to identify the individual phonemes, syllables, and words that are present. We don't have understanding yet. To understanding, we need to apply our knowledge of language to work out what the message is. And if it's all correct and makes sense, it's a very automatic process. If not, it's a very intensive process where we circle back and change our minds about things. Now, what happens? None of this can work without adequate attention and memory governing the process. What happens when we degrade the input? Initially, nothing, because all of this context lets us still understand everything. But if we degrade the input enough, then eventually we get no understanding. So if the signal-noise ratio is bad enough, we understand nothing. That's the result for, say, an average 6-year-old, and a particular 6-year-old has got a curve like that, And we know this child has got a loss of signal noise ratio or a loss of percent correct. Where is the problem though? Is it in this block or this block or this block or retention or memory? Answer is we don't know if all we've done is measure the whole thing. So we've used that structure to make tests which either measure the whole process like that, or only make use of auditory processing and speech sound recognition, but not language, or only make use of auditory processing and not speech sound identification. And then by looking at the differences between these, we can start to get very diagnostic about where the block is that's causing the problem. This test I'm going to talk about has been around a long time, LITS, around for 20 years. It sentences in noise, and the stimuli sound like they're either coming all from the front or from different locations, and they're either spoken by the same person or by different people. Okay, by using this structure, we can subtract scores and we can learn about the particular skills that people are using to identify the speech. I'm going to show you a bunch of results that look like this. They're large numbers, some of them, like 7,500 clients. And the vertical axis shows the Z score. That's the number of population standard deviations above or below average. And just as a guide to the eye, I've drawn a red dotted line at -2. So anything below that is more than 2 standard deviations below average for that age. I'm not saying that worse than -2 is always a problem and better than -2 is never a problem. Definitely, it's much more nuanced than that, but we've got to draw a line somewhere to help understand the results. So to be consistent, there's a line at -2 on all these graphs. So you should be looking at how big is this blob under the -2. Okay, so for the Listen-S test, it's 21% of children and adults coming in with normal hearing are outside that range. And if we look at those people, many of them have a reduced ability to use spatial cues. We call that spatial processing disorder, and we know it's a long-term consequence of otitis media in the first 5 years of life. Long after the otitis media is gone, the disadvantage is left behind or can be left behind. There's also a group of people who are not able to latch on to the differences in voice quality to recognise one target talker and ignore somebody else with a different voice quality. And there's also a larger group whom the problem is not spatial processing and not talker cues, it's something else. And Listen-S doesn't tell us what that is, just that it's there. If we turn the next lower down test, this is now using phonemes, not sentences. And again, we see a pretty big proportion of people coming in who are outside the normal range on this test. And we look at those people in detail. Again, for a lot of them, it's the same thing, spatial processing disorder. And also for a lot of them, even when there's no spatial cues, it's the ability, a reduced ability to identify individual phonemes when there's competition around, making that analysing job harder. Dichotic tests are used in almost every, if not every test battery in the world. And in a dichotic test, the person has to report back what they hear in the left ear and what they hear in the right ear, unless they're directed to just listen to one ear. But normally you have to say both. Well, we look at the performance on that, and again, fails or scores poorer than 2 standard deviations below the norm are very common in people coming into clinics for APD assessment. And we look at those people and we say, well, what about their ear differences? Well, for a big group of them, actually, they don't have any ear differences. Both ears are down in performance. But for quite a sizable group, they've got an ear asymmetry. And in particular, they've got a strong right ear. Now, everyone, or almost everyone, when they're a child, has a strong right ear. But what we're looking on this axis is not if it's strong, we're looking at, is it exceptionally strong, stronger than the normal distribution? So there's a lot of people who've got an exceptionally weak left ear and a small number also who have an exceptionally weak right ear. What makes this convincing is that if you instead change the task so they only have to listen to one ear, then indeed that the same asymmetry occurs in that directed task as in the free recall task. So it's a convincing score. All binaural processes are not the same. That's the dichotic task. That's the Listen-S task where you're listening to straight ahead. And if we plot performance of one versus performance of other, then there are certainly people who fail this test and fail this test. But there are also plenty who only fail the listen-S test, and also plenty who only fail the dichotic test. So if you're only using one of these tests in your battery, you're going to miss people. Language ability, this is a language test for audiologists. The client hears a sentence like, he went up and she went, and the task is to say what word is missing. It was obscured by a whistle. And it's measuring the ability to fill in the gaps. And indeed, there is a group of people coming in who have a sizable deficit, and a larger group who have a deficit but not as big on this test. And that's no doubt contributing to their reduced ability at understanding speech and noise. For memory, we're using a computerized version of the very commonly used digit span test, where people hear a string of digits and they have to repeat them back either in forward order or in backwards order, which measures working memory. Our computerized version works much like the conventional manual one, except at the end, it gives an extra set of trials that get harder or easier depending on how well the person is doing, and that makes the test significantly more precise. And again, there are groups of people who have deficits, large or smaller, in memory, which is no doubt contributing. How do these things fit together? Well, from various experiments, Jahan Zhu and Alicia Goodka, we know that phoneme identification is predictive of sentence perception, as is language ability, but maybe it also runs the other way, that people who have better sentence perception or phoneme perception develop better language. So it's hard to work out the direction there. Speech pathologists generally think the direction is downwards, language is the cause of everything, and audiologists who treat APD often think it's upwards, that language is the consequence of everything. I'm sure the truth lies in between. We also found that various non-speech tests were combined together to give us an overall representation of complex auditory processing, and that was predictive of how people understood the individual speech sounds. And with 10 seconds to go, extended high-frequency thresholds. In experiments with adults, we're finding they're quite a good marker of damage in the audiogram, but in children, not so. And I'm going to leave it there. There's a paper that has the philosophy of this, and you're willing to, I'm happy to send slides to anyone who writes to me.
Yeah, thank you very much, Harvey, for this condensed information. And now our next speaker is Susan Purdy. Susan is a professor in Auckland and in the School of Psychology. And she has also lots of years of work behind on the problem of APD. Please, Susan.
Thank you, Katrine, and thanks for the invitation. Are you seeing my slides okay? So now I'm going to talk about something that relates to what you introduced, Katrine, and it's very different from what Harvey talked about, because we've been focusing a bit, stepping beyond the diagnosis and thinking about the problem of many children actually not having the opportunity to have a diagnosis of auditory processing disorder because we have inadequate services to see all these children, and thinking about how could we help our teachers see this problem in the classroom to facilitate children getting to diagnostic services and treatment. So we've had several years of thinking about our classrooms and our teachers. And as we heard from Katrine, we're very familiar with the problem of noise, distance from the teacher, and reverberation with many reflective services in our classrooms. But in New Zealand and elsewhere in the world, not everywhere we know, there has been a big shift to much more complicated educational settings, sometimes called modern learning environments, sometimes called open plan. In New Zealand, they're referred to as innovative learning environments, and they have the schools that we've been looking at, there can be 104 children in a shared space who are grouped into different classes, but they're all there together. So, of course, the problem with so many children in a space is that there are multiple distractions, so a difficulty for our children with ADHD, but the possibility that you can be close to another group of children that's introducing noise that's additional to the normal problems in a single classroom. The other thing is that we have children who are in different positions while they're learning. They may be sitting on a beanbag or in the corner or lying on the floor or in a little chair. They aren't necessarily, they're definitely not in rows of desks, and they're definitely in different positions relative to the teachers. And there can be multiple speakers in the classroom. So this really poses a problem for our traditional ideas about how we help children to hear in these spaces. So we've had several master's students, two of our students, Benjamin Twin and Kate Westbrook, and Bill Keith and Justine Hui, who's a acoustics engineer, and myself have a chapter that's designed to help teachers think about how children can hear well in these flexible learning environments. Many of these classroom spaces have breakout spaces, but we know the teachers are not really informed about how to use these breakout spaces to help children to how to optimize signal to noise ratios. There's small and large group teaching. Pedagogically, there's a shift towards inquiry learning where children are learning things themselves, talking to each other. So the noise level goes up when inquiry learning is happening. And there's a lot of peer-to-peer learning. So we have had, with the help of our engineering colleagues, the opportunity to have days of continuous recordings of noise, signal to noise ratios and noise levels. So we know that the noise levels can be very good, but can be very high, that there's an enormous range of signal to noise ratios, and that the teachers themselves can speak extremely quietly as a way of managing the children's behavior in the space. The teachers vary in their speaking levels across activities and across teachers. So it's actually very challenging for our young children to be actually hearing and learning in these spaces. So traditionally, we've thought of our wonderful remote microphone hearing aids as an excellent technology. And that is true for a child who has a diagnosed auditory processing disorder in New Zealand. We're fortunate that our Ministry of Education will fund this technology, but it's quite difficult to wear this technology in the space where there's multiple teachers unless we have some kind of system where the child is able to manage the teacher's microphone, or the teachers are really working well as a team to make sure that the right teacher is wearing the microphone for the child during that activity, or the child has the opportunity to use a microphone when they're working with their peers to hear their peers. There has, because of the complexity of modern educational settings and some of our, especially our primary school classrooms or elementary school classrooms, people have started to think more about low gain hearing aids for children who have normal or near normal audiograms and evidence of auditory processing difficulty. And as Katrine alluded to, we don't really have strong evidence yet, but there's increasing interest in this, and I'm sure that there will be publications in the future. I just put this slide up here because this is a paper that looked at US veterans in the US, and they identified veterans who had normal hearing thresholds but self-reported hearing difficulties, and other veterans that had, or other service members who had hearing impairment, loss on the audiogram, and self-reported hearing difficulties. And you can see on this figure from the study where they're measuring a global hearing aid benefit measure, that basically you have equivalent self-reported benefit for the people with normal audiograms and self-reported difficulties and those who had a measurable hearing loss on the audiogram. So at least for adults with listening difficulties, we know that low gain hearing aids can be a solution. And anecdotally in New Zealand, we know that audiologists are trialing low gain hearing aids rather than remote microphone hearing aids, especially with older children who are moving between classrooms and have multiple teachers. So we have, with the help of a number of master's students and my colleague, Dr. Nuzit Sultana, we've been talking to lots of teachers about what they know about auditory processing disorder and how they might support children with hearing loss or auditory processing disorder in their classroom. And some of the teachers that we've interviewed across our country, across New Zealand, have actually taught children with a diagnosis, and others know about it but have never, to their knowledge, had a child in their classroom with a diagnosis. And I've just put up these two quotes. One is from a teacher who's had experience with children with APD, and she described them as kids who cannot follow instructions unless I've given them to them directly, looking at their face. Kids who don't respond, like straight away if I call their name. Kids who have difficulty following more than one or two instruction sequences. These would be major red flags that would point me towards APD rather than another issue. And this teacher and others have talked about how they see this as presenting differently, although we know there's an overlap from autism or dyslexia or ADHD, for example. And then a quote from a teacher who'd never really seen a child that they thought was diagnosed, but had heard about it. And she said, well, is it like a delay in understanding, or if there's lots of noise happening, it's sort of difficult to take in. So I think these interviews with teachers have highlighted how they have some knowledge, they want more knowledge, and they're very keen to learn more and support children. So in some other interviews with teachers in these large teaching spaces with 100 or so children, they've sort of talked about ways that they could help a child who has hearing difficulties by, for example, having the teachers in the space work together more so that they can share their scheduling so that they're not actually competing, so that you don't have 4 groups of teaching groups who are doing noisy things over here and trying to be quiet, listening and learning over here. They also talked about strategies to promote the children to learn independently so that they're less dependent on hearing their teacher, and also teachers who are aware in these large educational spaces that they can hear other teachers doing things that they think are not ideal for children's listening, how they could have mentoring. What we have found is that teachers are quite variable in their use of breakout spaces or optimizing small group learning so that children can hear, and that they don't really know about the idea of improving the signal to noise ratio. The other thing we've found is that teachers are not using their voices optimally, and in some countries, voice care and use is part of teacher training, but it tends to disappear as teachers get so busy learning about everything else. So we encourage that teachers are keen to learn, but concerned that there's little opportunity for them to learn about these things. While we've been doing this research, talking to teachers and making measurements in the classroom, we've also been looking at questionnaires that have been developed by various people to help teachers evaluate children's listening behavior. So one of these is a tool, the TEEP, the Teacher Evaluation of Auditory Performance, which has been evaluated in a number of studies. When I developed it some years ago, it was based on existing questionnaires, but our goal was to reduce it down to 10 items. And I'll show you a little bit of data from a study that Bill and Joan and Melissa Bailey and I did a few years ago. And then we've had a master's student, Shirley, looking across the literature. People are increasingly using these questionnaires, such as the Auditory Processing Domains questionnaire, which can be completed by parents or teachers, but we have observed in the literature that mostly people are getting parents to fill in that questionnaire because it has 50 items, and getting a teacher to have time to answer a 50-item questionnaire is a challenge. When we've looked at TEEP scores, this is from a study with about 58 children in it. We had children diagnosed with auditory processing disorder and control children from a school of similar age. And if we just draw a cutoff line in terms of above this, you have healthy listening, and below it, maybe you have some difficulties. What we were able to see is that all 28 children fall into the category of having listening difficulties based on the teacher report. And then only 9 of the children who didn't have APD fell into the category of having listening difficulties. Anecdotally, interestingly, a couple of those children were children in the classroom where English was the language of instruction and that English was not their first language. So we're encouraged by this study to see that these questionnaires could be used reliably by teachers to identify children that should go on and have diagnostic testing. But we also have interviewed teachers about these paper and pencil questionnaires, and they are problematic for busy teachers. So at the moment, we're looking at sort of digitizing and modernizing and making a questionnaire online that's more accessible for teachers, that can give teachers information along the way and also guidance about what to do if they identify a problem. So that's my quick look at what we've been doing with our teachers about this problem of finding children with APD and supporting them in our classrooms. So thank you, Katrine, and I'm handing over, I think, to Joan.
Yes, thank you so much, Susan. I hope we have still the opportunity to discuss several of the points you all made or will make together in the end. You can, the participants can write their questions into the chat and we try to reply them. However, we also will have an oral discussion thereafter, and I all invite you to raise your hands after the end of our webinar and to participate in our oral discussion. Our next speaker will be Joan Leung. I'm not sure, Joan, whether I pronounced your name absolutely correctly. Joan comes also from Auckland. She is a postdoctoral research fellow and professional teaching fellow at the School of Psychology in the University of Auckland, where also Susan's place is. And I'm very curious about the question you want to answer for us about the necessary duration of amplification treatment and neuroplastic outcome. The floor is yours.
Thank you, Katrine. Can everyone see my slides okay? Nice. Hello, everyone. Thank you for tuning in to this very special webinar in celebration of World Hearing Day. Happy World Hearing Day. And thank you very much for the invitation and opportunity to present, Katrine. I really appreciate it. I'm Joan, and I'm going to be sharing some results with you from our study looking into the duration of amplification treatment that we did here in Auckland. I would like to acknowledge our co-authors, Bill Keith and Suzanne. As you can tell from Suzanne's slide, we're just a little team here in New Zealand, but we're very lucky to have many colleagues all around the world. Oh, slide. Okay. So there is strong evidence that remote microphone hearing aid systems or RMHA systems benefit most, if not all, children with auditory processing difficulties. Evidence suggests that there is a double benefit of sorts, if you will, both assistive, which refers to immediate hearing assistance, and therapeutic, which refers to more permanent improvements in hearing skills over time, suggesting neuroplasticity at play. The current working theory is that amplification facilitates more neurons to fire or activate together at the same time, which may in turn then facilitate the creation of more synapses or connections between these neurons, which then strengthens the representation of auditory signals in our brains. So in our study, we set out to try and answer or to investigate the question of whether amplification engenders neuroplasticity, and if so, what duration of use of RMHAs are actually needed. There is a gap in the literature, so neither actual nor optimal durations of use have previously been reported. So we retrospectively studied remote microphone hearing aid system use in 41 children recruited from the Sound Skills Auditory Processing Clinic here in Auckland. The duration of use data were drawn from a subgroup of 30 cases out of these 41 children, fitted at least 4 years prior to the time of the study because we didn't want to skew our data if the children were too recently fitted with the RMHAs. So first, let's look at how long children wore RMHAs for. So the actual average duration of use was 2 years and 9 months, but due to the heterogeneous nature of APD plus the effect of comorbidities, there is a wide range of durations from 4 months all the way to over 6 years. The graph on the right is showing about 50% of these children stopped using RMHA systems at around the ages of 10 to 11 or school year 6. We also kind of tried to estimate the optimal duration of use by averaging the duration of use in children where hearing difficulties were resolved. And so we estimate the optimal duration to be around 2 years and 5 months, which is quite in alignment with the actual average duration of use. More qualitative data from our study revealed some of the reasons why children stopped using RMHAs. And these were obtained from parent questionnaire data and also thematic analysis of interviewed transcripts from a subset of 11 parents and 8 children. So from the questionnaire data, 2 of the main reasons for stopping the use of RMHAs were that children were either self-conscious or that they were coping better. No one said RMHA systems were not helpful, so that was nice. And a further significant theme from our thematic analysis described the inconvenience centered around classroom environment transitions, in particular having to give the remote microphone device to multiple teachers, which possibly also then contributes to the self-consciousness factor. And Suzanne's already touched on that when she talked about the classroom listening stuff. We also analyzed the duration of RMHA use by age at which children are fitted. And children who were fitted younger tended to use RMHA systems for longer, as you can see on the graph on the right, which suggests other amplification students may be better accepted in older children, especially if, again, this self-consciousness factor is at play. Then we and part of the kind of last parts of the results is that we try to investigate some of these changes in alignment with potential neuroplastic or therapeutic effects. So we had follow-up test results available for 26 out of the 41 children in our cohort. And the results here on the y-axis on the graph on the right show the percent of APD tests failed from tests carried out at assessments conducted before and after the use of RMHAs. So we've got 3 bars here. The baseline bar refers to initial diagnostic assessments. We then have an adjusted baseline, which refers to these initial assessments, but the scores were adjusted for 6 children who received and improved from additional ARIA therapy for dichotic listening, developed by Deborah Moncrief. And then the last bar on the far right is the follow-up, which refers to the final percentage of tests failed, APD tests failed after the completion of wearing RMHA systems for a period of time. So the results showed that the difference between baseline and follow-up was statistically significant with a reasonably large effect size. We were glad to see that this effect was retained after adjusting for the dichotic treatment-related improvements. And so you can also see that the difference between the adjusted baseline and follow-up was statistically significant with a moderate to large effect size. Post-treatment, 12 of these children no longer qualified for a diagnosis of APD, according to both the American Academy of Audiology and the ASHA criteria. Ooh, okay. So that was really quick. But those are our kind of main findings from the paper. Someone on the chat asked if we could share the slides. I'm not sure about the other people, but for this one, we are very close to publishing a paper. So if you'd like to email me at that email, I can keep you posted as to the results that I've presented today. Thank you for listening, and thank you again, Katrin, for the invitation.
Thank you so much, Ron, for this absolutely interesting and fascinating presentation. It is my pleasure now to introduce Amelie. Amelie is senior physician in the department which I chair and postdoc fellow, and she performs together with me a large study on extended indications for remote microphone technology, or maybe later on with not only maybe, it's sure, with low gain amplification hearing aids. So, Amelie, please, the floor is yours.
Moment to share. So, can you all see my slides? Okay. Hello, everyone, estimated colleagues. I'm happy to show you some insights to our ongoing prospective study about extended indications for assistive devices in children with listening difficulties. We've heard a lot of background already, so it's just a short introduction. As we have already heard, there have been multiple benefits of remote microphone hearing systems, also called assistive listening devices, shown in the literature. And there is a frequent co-diagnosis of dyslexia and APD. Estimations go up to 50%. There have also been therapeutic and neuroplastic effects shown in children with dyslexia. For example, improvements in phonological awareness and reading in a controlled trial by Hornickel et al. Amplification has also been suggested to enhance speech therapy effectiveness and to improve phonemic awareness learning in typically developing children. Another group of children with hyperacusis also often complain about background noise in the classroom and being easily distracted by noises in everyday life. Some other studies suggest that RMHS may also be beneficial for children with dyslexia, autism spectrum disorders, who, as many of you know, often complain of hyperacusis as well, and with attentional and other learning disorders. That's why we are currently performing a multi-arm prospective study assessing in the first part children with APD diagnosis with and without measurable listening difficulties and noise, and in the second study arm an RCT in children with dyslexia with and without fulfilling the criteria for APD diagnosis, as well as 3 non-controlled study arms with hyperacusis, autism spectrum disorders, and learning or intellectual disabilities. And we are performing quite an extensive audiometric, psychologic, and speech-based testing battery, including nonverbal intelligence diagnosis and also criteria for ADHD. But I will go over this quickly. If needed, also reading and writing tests. The study is accompanied by several parent, teacher, and children questionnaires assessing listening difficulties and symptoms in classroom and everyday life, as well as hyperacusis complaints with a mini hyperacusis questionnaire, and psychosocial and behavioral well-being in the child's behavior checklist for parents and the teacher's report form for teachers. So some first results: the subjective conclusion of RMHS supply in the various study groups. up to now, you see the study is still ongoing, so there are still some children under testing. But as you can see in the green bars, in all study arms, a majority of children wants to go on using the RMHS. And if this is green in the case, then child, parent, and teachers agree that the child should go on using the device. There are some children stopping the usage in every group. And this slide shows you the reasons over all study groups. So we have seen some children who subjectively didn't have a benefit of the RMHS. Then high proportion of discontinuation reasons are because of shame or mobbing because of the devices. And some children also complained about hearing the teacher too loud. This was the case in some of the children with hyperacusis, as you will see later. And in few cases, teachers didn't cooperate. Then we started the study during the COVID-19 pandemic, and just when children didn't have school in presence, of course, the RMHS wasn't applicable. Yes, and then of course some children have a mix of reasons. Because we didn't give them pupil microphones. Also, one child complained about hearing the other pupils less, and one child had wanted to try out low-gain hearing aids because it had also listening complaints in other situations outside the classroom where the remote microphone hearing system wasn't usable. Here you see the comorbidities. Of course, in the first two study arms, all children have a diagnosis of APD, but as you can see, and in agreement with the literature, we have a high co-diagnosis of dyslexia and auditory processing disorders. Also in the hyperacusis study arm, we have some children, when tested for APD, then they got an APD diagnosis. In these two study arms for learning disorders and autism spectrum disorders, we rather call it auditory processing difficulties because they obviously not have a low IQ, or some of the children with autism, hardly. So they don't fulfill the strict criteria for APD diagnosis. Yes, some first results for our hyperacusis study arms, which is full, with 15 participants with subjective hyperacusis diagnosed with using the discomfort threshold level and the adapted mini HQ9 hypersensitivity questionnaire adapted for school children. We see also an overlap with misophonia in 3 children, as I showed you, an overlap with auditory processing disorders and also with developmental language disorders. Up to now, no single one of those 15 children has got a diagnosis of ADHD, but according to the ADHD ICD-10 symptom criteria checklist, which is still valid in Germany, we are still working with ICD-10 in the clinical assessment, like fulfilled by the parents. 3 children were noticeable in the area of attention, 3 in the area of impulsivity, and 2 hyperactivity. All of the children use the RMHS mainly at school, and interestingly, 9 children of the 15 subjectively benefited and wished to continue this usage, and 6 of those didn't have an APD diagnosis, but only a hyperacusis. 3 had hyperacusis and an APD diagnosis. 6 children stopped the RMHS use due to various reasons. When we look at the score in the mini HQ9 questionnaire, which we could understand maybe as a measure for burden of hyperacusis in everyday life, then we see a reduction in the median in all 15 children, but not significantly. when we look only at the 9 children with subjective benefit, who were the ones who really used the device the complete 3 months, some of the other stopped it quickly, then we see a significant reduction in the mini HQ9 overall score. And these are some first preliminary results of the still ongoing study arm in dyslexia. When we look at the psychosocial and behavioral well-being in the parent and teacher questionnaires, CBCL and TRF, we can say that in the short term, there is no influence of RMHS use on fundamental personality traits such as anxiety, depression, or withdrawal, but we seem to have some significant improvements in the subscales learning, school, attention, and aggressive behavior. When we look at the teacher questionnaires, the listening inventory for education revised, telling a so-called classroom listening score, then we see an improvement in the median from before RMHS supply and after 3 months of RMHS usage, but not significant. And in the academic and communication skills, according to the SIFTER questionnaire, we up to now don't see any real change. So to conclude, we can say that in addition to children with APD alone, children with dyslexia, hyperacusis or misophonia, as well as learning or intellectual disabilities, maybe also multiple disabilities, and children with autism spectrum disorders often have listening or auditory processing difficulties or APD, and they often benefit from RMHS usage. So in our opinion, it's worth trying to provide them with this technology. Thank you very much for your attention, and best regards from Münster.
Thank you so much, Amelie. Interesting, and as much as our study grows, we learn a lot by ourselves. And now it's my big pleasure to announce Professor David Moore, who is Professor Emeritus at the Cincinnati University and Manchester University, and worked for a long time at the Oxford University, and also as at the MRC Institute of Hearing Research in Nottingham. Listening difficulties, are they speech specific? I'm very curious, David. Please unmute yourself, David. We didn't hear anything so far.
Okay.
Yeah. So
We've got
now,
contact. Yes, sorry about that.
now.
So I'm going to address a very specific issue today, as per my title, about whether listening difficulties are speech specific. And I'm going to do this using purely objective technique of magnetic resonance imaging. And I've worked with many colleagues on this overall study of which this is a part. And I'd particularly like to mention Hannah Stewart, who is a postdoc who did most of the work in my lab in Cincinnati. So as we've heard, listening difficulties are very commonplace, and in fact, it's the most common reason for people to seek help with their hearing, in particularly speech hearing in challenging environments. And we know that listening is dependent on both auditory and cognitive function. And in fact, that's why we use the term listening rather than hearing per se, because it's to emphasize the cognitive element. And cognition, for those who are confused about it, includes almost everything that is to do with the brain, but certainly attention, memory, speech, and language, as other speakers have said. So we did a study called the Cichlid study, which we've now published several papers on, in children aged 6 to 12 years, with or without listening difficulties, based on a caregiver questionnaire called the Eclipse, which is widely available. If anyone wants to use it, please get in touch with me. But what we ask specifically here is whether non-speech sounds or speech sounds are more predictive of neural functioning in the forebrain of these two groups. So, as I said, we've used fMRI, and one of the aspects of this particular resting state type of functional magnetic resonance imaging is that it's done without any specific stimulation. So the child's just in the scanner and doesn't hear anything. We just take a map of the activity of the brain. So here's a representation of the sort of data we come out with. The blue nodes here represent all known areas of the brain which are connected with speech. And so they're not from our data, they're from a meta-analysis of all the studies that have been done using MRI to look at speech processing. The red parts connecting these blue dots are our data, and the strength of the red lines is an indication of how strong the correlation is between the firing of these different areas of the brain. As Emily, or I think it was Joan actually, just suggested, neurons that fire together wire together, and that's a fundamental part of neuroscience. So we can see in these what we call typically developing children, that is those whose parents said that they had normal types of communication function, that we see a slightly stronger representation on the left side. We see heavy interhemispheric connections in the middle picture there, and then we've still got a substantial amount of connectivity and loci for speech occurring on the right side of the brain. So I want you to try and keep this image, which is averaged over about 30 children, in your head as we go through the next couple of figures. So here's what we see when we look with non-speech sounds. Now, when we talk about this, just bear in mind we're not actually delivering these sounds. What we're looking at here is the parts of the brain that have been found in MRI studies to process non-speech sounds, by which I mean things like tones, clicks, environmental sounds, music, everything except speech. And the first thing you'll notice is they're very similar to the previous figure in terms of distribution, which you might expect since they're sort of auditory based with cognitive connections as well. And you can see now for the first time we're adding age as a variable here. And you can see, as you might expect, that 6 to 7 year olds are very well developed. But if you look down, you can just see, eyeballing this, that as we get older, those connections seems to strengthen up a bit. So that's the typically developing kids. And if we go to the kids with listening difficulties, we see something that looks very, very similar. And in fact, it is very similar. Statistically, we've done all the quantitative analysis of this, which I'm not going to present today, but you can see that basically we're seeing the same pattern of slightly increasing connectivity, both sides of the brain and so forth. And everything there looks normal for connectivity concerning non-speech sounds. Now, let's go to speech sounds. And again, I'm showing essentially the same picture as the big one I originally showed, but this time breaking it down into different age groups. And again, you see the slight developmental progression. But here, I think it's a lot clearer that the left side of the brain has got more processing capacity than the right side of the brain, which is what you would have expected from the literature. So these are the typically developing kids, and now I'm going to show the kids who have listening difficulties. And you can see immediately that the connectivity in these children is way less than the connectivity that we saw in the typically developing children. And I must emphasize that there's no stimulus being presented. All of the data gathering was done in exactly the same conditions as for the typically developing children. And we have done the statistical analysis of this, and there's an overwhelmingly increase in or greater level of connectivity in the typically developing children than in the children with listening difficulties. So I just want to show one more data slide here, which is we're relating behavioral and neural function. So what we're looking at here is different parts of the brain going in a sort of bottom-up progression from the thalamus to Heschel's gyrus, the primary auditory cortex, within the primary auditory cortex out to secondary auditory areas, and then finally out to frontal cortical areas. And what we're doing is correlating the degree of connectivity, as shown in the previous slides, with different behavioral measures, most of which people in this group will know about. We've talked about the Eclipse as a questionnaire, Children's Communication Checklist is a questionnaire, the SCAN test is the most widely used test for auditory processing disorder in the US, ListenS, Harvey gave an extensive introduction to that. And then finally, the NIH Toolbox is a collective measure of cognitive function. And what you can see is that the hot areas, the redder areas, tend to be seen with increasingly forward-moving connectivity in the brain to be focusing on the questionnaires. If you look at the SCAN, which is the well-known test for APD, you see that's also improving and shows moderate levels of correlation. However, the ListenS, the speech and noise test, is probably the weakest of all of these different categories of tests, especially as we move to the more frontal areas. And finally, the cognitive tests are also in the moderately strong area. So perhaps counterintuitively, what we showed in this particular slide is that questionnaires are most predictive of neural function associated with listening difficulties, and the cognitive tests are generally more predictive than the hearing tests. So just to conclude, what we've found is that listening difficulties in children are associated with reduced functional brain connectivity for speech, but not for non-speech sounds. And the association with brain connectivity is most strongly predicted by questionnaires and cognitive tests rather than auditory tests such as those commonly used for APD and perhaps surprisingly for speech and noise. And I should go back to the introductory slide that Katrin showed where there was almost total overlap between children who had developmental language disorder and children who had auditory processing disorder. And I think what we've shown here is objective evidence to back up that extremely strong link. So thank you for your attention.
Dear David, I'm very grateful for this presentation and the outcome. Good. Last not least, it's my pleasure to announce Mridula Sharma, professor at the Flinders University, but also with affiliation still in the Macquarie University in Australia. And she will give the last speech before our discussion starts. Predictors of degraded speech in school-age children with listening difficulties. Please, Mridula.
Thank you. So I'm the lucky last. Hopefully you can see my slides. Okay, so thank you, Katrine, for organizing this, and to ISA and IOP for collaborating on this. So let's get right into it. Okay, so spoken communication occurs in spaces with noise and reverberation. Now, this is something Katrine, you spoke about, Suzanne spoke about, Joan spoke about. I think we've all agreed that classrooms are noisy. And why does that matter? Because they do cause interference. And this is not just true about classrooms. I think world in general tends to be very noisy. So understanding speech when there is not just noise, competing noise, but there's echo as well, remains one of the biggest challenges. It's been reported, it's come from NHS database, that 5% of children and 4% of young adults who come into the audiology clinics who do not have a hearing loss, based on PTA, still complain about listening in noise. So this is a real concern for us. So, like I said, when it is noise, it is a simultaneous masker, and what it does is it obscures the less intense signals. Manner of articulation are the first sounds that get masked very quickly, which impacts your general understanding of the signal. And a reverb or the echo causes temporal smearing, and that causes the blurring of the edges of syllables and words. And in other words, the clarity again gets impacted. So recognizing and understanding speech in this environment is difficult for adults, but it's more so for children. There is research that shows children require higher signal to noise ratio to understand. And once again, classroom is noisy. So hopefully everyone's convinced this is a problem. So while this is convincingly available in literature about listening concerns, what we don't know is what are the relevant factors that contribute to our ability to listen and recognize speech in order to understand it. Thank you, David. That was a very fascinating study you showed that gives us some inkling of what are the factors that may be contributing to our ability to understand speech. So hopefully this talk will contribute a little more as well. So what does the literature tell us? What are the factors that are important? From looking at adult data, some of the adults with hearing loss, older adults, some of the things that have come out repeatedly in literature are language skills are important, cognitive skills, especially attention, working memory. But then in auditory processing, we had to use a little bit of common sense logic in order to try and create a model. And we think dichotic digit test, which is looking at listening across the two ears simultaneously to know what the signal is, should be an important factor. And that's what we were interested in investigating that. Both speech and noise and dichotic listening require focusing on one stream while inhibiting the other. In older adults, that is one of the studies I've cited there, dichotic listening has been associated to speech perception and noise. So this is some of the background that we used to try and create a model. So this is what we thought. These are the factors. So there's auditory processing, attention, language, phonology, working memory. These should be the factors that contribute to listening in noise. And we went on to then look at is there a significant model and how do these factors, if at all, contribute to listening in noise? This data is 90 children that I had collected a long time ago in New Zealand. I'm going to keep looking at this data till cows come home. So here's another one. These are kids who are aged about 7 to 12 and a half. And we first did this multi-regression analysis. Our dependent variable was BKB sentences, and I had used 65% compression and 0.3 second reverb. And the reason we took this reverb was because between 0.1 to 0.3 second is about the background reverb that's often reported in classrooms, and 25 to 20 dB below the voice level at 1 dB when you're listening to sound at 0 degrees azimuth. So given that, we thought this would be a reasonable I guess, parameter to evaluate listening and noise for kids. We looked at dichotic digit tests. We looked at phonological awareness using manipulation or elision, where you swap sounds to create new words. We looked at language content using the CEL4, and then we also looked at attention. We actually also measured their working memory, so a memory model, and we looked, given the fact that we were testing children from 7 to 12, age had to be a part of the model. So first we did the good old multi-regression, and no surprise there, we found that age, memory, attention, phonological manipulation, and language were significant contributors, and we were able to explain 45% of the variance. That was reassuring, but it was curious that, while we were fishing, as you do, when we removed the attention, because dichotic digit test, as Javi would say, has a pretty strong attention component. And that said, we thought there was shared, variance for these two. So one way around this is, rather than looking at a linear model, we decided to look at a structural equation model to try and figure out what are the mediating paths between attention and auditory processing. So this goes to try and understand the interrelationships between the variables. And what we found is this model. So attention, please focus on the red lines. And the bottom line here is, now, given these are only 90 children, every line means you're kind of splitting the variance. So ideally, structural equation modeling should really be done with at least 100 or more if you're going to be having these many relationships. But 90 was, my statistician told me, was just about okay. So we do have to take this model with a little bit of pinch of salt, but nevertheless, it was interesting to observe that dichotic digit was contributing directly to our listening and noise sentences. When we tried to look at mediating path with phonological manipulation, for instance, while that relationship is significant, it is not a significant relationship to BKB sentences. Attention was working through dichotic digit test to listening and noise. So the attention did not contribute directly to BKB sentences, but it did through dichotic digit test. So what does all this mean? What this means is that, one, dichotic digit test, so auditory processing, is contributing to listening and noise. Sorry, David. And that attention is important because it contributes indirectly through dichotic digit test to your listening in noise. Now, like I said, we only had 90 kids, so the contribution and the role of language could not really be clarified in the model, but it makes sense. You're listening to sentences, they're not meaningless. They actually are meaningful. There is context. So I would assume that language is an important aspect as well. What's my takeaway from here? Speech and noise, it's not a unitary task. It's not dependent on one skills. There are several skills involved. And I think attention, auditory processing, as measured by dichotic digit, and potentially language are relevant skills. And when looking at interventions, we need to consider all of them. So thank you for listening.
Thank you for this very interesting presentation. I learned a lot, Mridula. So now we have tried to reply the questions coming up in the chat, but now we have the opportunity to have an oral discussion. Who of the audience wants to start? Please raise your hand. and we will be happy to discuss with you. If not, I start with the last point, Mridula. I remember that Bill, and we have the people from Auckland here, Bill Keys mentioned several years ago dichotic listening difficulties will profit or do profit from dichotic listening training. However, not from remote microphone technology, from improving speech in noise. For example, has this to be reconsidered?
So just to rephrase, you're asking whether if we are looking at dichotic digit test, should we be looking at remote microphone or that ARIA test or dichotic listening test that was promoted by Musique and Deborah Moncrief? Is that right? Yeah.
Can I just,
sorry.
before you answer, Mridula, just a little twist on what you said, Katrine, about Bill's comments. What Bill has said is if there is, and Joan has worked on this more directly than I, if there is amblyaudia, a big ear difference in dichotic processing, Bill is saying you should treat that before you put on remote microphone hearing aids.
Okay.
There you go. That's the answer.
Okay.
No, but you were going to say something else, Mridula.
Oh, I was just going to say, I mean, I guess when we are talking about the way I'm looking at dichotic digit test, I wasn't looking at amblyaudia or presence or absence of it. I was just looking at dichotic digits as a measure of how the two ears work together. It's a measure of that. And we looked at its contribution to listening in noise because listening in noise is something that requires the two ears working together. So to me, it was a logical relationship to explore. So if there is, and I agree with Belle, if the two ears are functioning such that they are not aligned, there is a big difference. We do have to address it because otherwise, we've seen this. Kids who were unfortunately trained by Tomatis, where they're forced to listen to one ear. You see that when you're trying to look at their performance, it's almost like the other ear that they've been asked to ignore, it doesn't exist. It's I think, yeah, we do have to make sure that the two ears are functioning as they should.
Joan, do you want to mention about the research that you did with Bill where you were using the remote microphone hearing aids because they have a small gain adjustment to look at children with amblyaudia?
Yep, sure. We haven't really finished yet. We have very small participant numbers because New Zealand is a small country, but we've kind of piloted the idea of using remote microphone hearing aids and adjusting the gain so that it's kind of like where you patch the eye to fix amblyopia. It's the same concept where you patch the strong ear and you make the weak ear work. And then over a course of 8 weeks, we try to adjust the gain on the remote microphone hearing aids until they are even with each other. Can't really comment on the results yet because we've only done preliminary analyses with a very small number of children. But qualitatively, a number of them said that they've noticed a little bit of a difference, a little bit of a benefit, but that's still in progress.
We have a question by Naisha Piri. I hope that I pronounced this correctly. Please, George, give Naisha the opportunity to speak.
He's got it.
Hello.
Hello.
Can you hear me? Yeah, I'm Manisha Piri in Malawi. we working at Queen Elizabeth Central Hospital as an audiologist?
Or put off the microphone.
My question is,
Ridula, switch off the microphone.
hello?
Yes, say it again, your question, please.
Is it muted? Okay, I'm saying, so my question is, it's about the remote microphone, the remote microphone for hearing aids that has been proven to work well with children with the auditory processing disorder. So my question is, in our setting whereby we are still lagging behind in terms of these remote microphone, we don't have them. Is there another solution that can help our children in our low socioeconomic countries?
Yes, if I may reply at first, but you all can contribute. Therefore, I brought it up that what we did also in schools, because there was no reimbursement of remote microphone technology or sound field technology, which would be wonderful. We had parent initiatives who covered the wall, for instance, one long wall with curtains. And this helps already a lot. So improving classroom acoustics, also acoustic ceiling has not to be that expensive, might be a good solution. Maybe my colleagues have other ideas.
Can I add? I don't know enough about this to tell you sufficient detail, but we have a trial in New Zealand of a inexpensive amplification system in classrooms to support many children. So if you emailed me, I could connect you with the researchers who are conducting that study at the moment, as a sort of a solution for a classroom that has many children with listening difficulties in it.
Very good. Thank you so much,
Yeah.
Susanne.
Sorry, can I clarify? Suzanne, is that the shock headsets one, the Tasman study? No.
No, you should talk about that. No, I think it is different. It's Matthew Barker and Lisa Syrup in Wellington in New Zealand. I've just heard from other people, so I need to know more detail about it, but I could connect our inquirer with them so they can learn more about it. It's
it would be good.
exploratory, yeah, but
it would be good to know, because we have
Yeah.
been wondering about it as well. We have got children with otitis media, and there are huge waiting lists, etc. And we are trying to figure out how to improve their signal to noise ratio. The classrooms have loudspeakers, but that doesn't really help because the acoustics is a problem. So we need personalized solutions. So one of the things we were trying to consider were these shock headsets, if you can see them. These are, what's her name? I said it wrong. Her name is Tamsin, I think. She's got a publication from UK, and I think she ran a trial in Rwanda with children with these headsets and in classrooms. And what these do is these are bone anchored headsets. So bikers and joggers use them.
Interesting. Send it to all of us, Ridula and Susanne. We are all interested in such solutions. There's a question from Shalim Ahmed Ali, was already partly replied to in the chat. He wrote, "Hi panel, thank you for the wonderful webinar. I have a question. A young person with autism case, if the PTA was moderate hearing loss, but ORA was fine. Would this explain they have APD or likely to malingering? So maybe Susan and Mridula, you just once more reply for the whole audience.
You go, Suzanne.
This was a question related to the moderate hearing loss and the present otoacoustic emissions, which without knowing from our colleague without what other tests were able to be done, we can't really know, but those two results combined as a sort of a red flag for auditory neuropathy spectrum disorder, which could be something that's co-occurring with autism, but autistic behaviors could be associated with an undiagnosed and untreated auditory hearing loss, especially a hearing loss like ANSD, which can be associated with very poor speech recognition or speech discrimination. So I'm hoping that our colleagues who asked that question will be able to find out more for that child. Yeah. So, and as Joan said, I think we wouldn't expect a pseudo hyperacusis or malingering, I guess, in a child in the first instance, but we might also think that if a child is struggling with the situation, that perhaps the pure tone thresholds, Mridula, you can answer this better, might not properly reflect their absolute hearing levels. Actually, Emily, you can also answer this. You're doing all this work. Yeah. So it's a really good question and a great example of how often in audiology we don't really know until we've done a whole lot of things. And here we are, we're doing all these assessments with APD and we still don't really know. Yeah.
Thank you so much. I have a remark to David and a question. The remark is, so I'm so happy that we, after all the years, the struggling is APD related only to non-speech acoustic signals, or should it be restricted to only this? And we see such a strong evidence for speech there. And we just run an MEG study and have with children with developmental language disorders, where because they are older already, 10 to 15 years, we do not see many symptoms any longer. However, we have strong, significant differences in amplitude modulation and in temporal response function, which shows into the same direction as you showed. But there is a question to you from Harvey. Harvey, don't you want to ask the question orally?
Oh, I'll read it out. So, Dave, you found that the speech and noise ability measured with listen wasn't much correlated with neural connectivity, but the ECLIPSE questionnaire, which I presume is the total score for ECLIPSE, was correlated with neural connectivity. So what type of deficit do you think the ECLIPSE was actually measuring in your sample? I mean, it's multiple scales. Let's just start with that.
Yeah.
It seems like we started by saying here's a speech and noise problem, but that's got nothing to do with anything, is the answer.
Well, I mean, I wouldn't exclude it. Obviously, there's both APD, however that's defined, or listening difficulties. And, you know, it's a curiosity to us as to why we found that particular finding. You've got to remember that when you're doing MRI work, there's a thresholding issue going on. And so it's possible that what we were showing, what I presented today, it's not artifactual, but it's actually highlighting perhaps the most important or the most prominent parts of the system. Another point I would make is that we're looking across the whole of the forebrain. And as you saw in all of the pictures I showed, there's a huge amount of wiring there or connectivity that's not actually part of the conventional auditory system. So coming back, I guess, directly to your question about why, speech in noise was not as prominent in the correlations, I think that actually points to the higher involvement of other systems than the auditory system in the connectivity data that we showed and in the Eclipse questionnaire, which, as you will know, but probably many others don't, covers a whole range of different issues, not just auditory issues, but some of the other issues that have been highlighted in the symposium today, like difficulty understanding directions, difficulty with attention, and so forth. So I guess that's not a very complete answer to your question, but they're just a few sort of initial ideas as to what's going on. And just to summarize, I agree with you. It seems a strange observation to have made, but that was the observation we made objectively, and we have to try and figure out a way of interpreting it.
Yeah, thanks.
Can I just, I don't know if you've got another question burning, Katrin, but I wanted to ask Harvey a question, which is, given the overlap that everybody knows exists between APD and a whole lot of other neurodevelopmental disorders, I want to ask whether your approach of trying to separate all of the different connections between the different types of tests that you've developed, you showed how each of those tests was pulling out a group of people who were performing very poorly. But my question would be, what was the co-occurrence of those problems across the tests you've used? So, I mean, what we would predict from a lot of literature is that, an individual who performed poorly in one of those tests that you use would actually perform poorly in several or even all of them.
Yeah, it's not that clear cut. The answer is all of the above. I showed one example where you had dichotic test results and ListenS. And so you do have people who have deficits in both, but you absolutely have an approximately equal number who have deficits in just dichotic and another group who have deficits in just ListenS. So if you think of a combination that could happen, yeah, it's in the data. The more interesting question is, how often do you get various combinations? And that's a really active area of research at the moment. And the more data that goes into the portal, the better we can answer that question.
I have the question, and if not, we could do it, Amelie. Is somebody doing a study about the neuronal correlates of, let's say, wearing or using remote microphone technology for 2.5 years and longer? Or low gain hearing aids, that would be really worth, with before and after, of course, long-term follow-up of wearing those devices. If not, we really should do it.
Yeah, Joan, you can answer that.
Do you mean Katrin's question or the question in the chat?
No, Katrin's question. So for EEG, people have done those studies, usually not over such a long period, Katrin. For Nicole, I think for her PhD, maybe with Nina Kraus in the lab, they followed the children who had a diagnosis of dyslexia for a year and were randomized right
I know
into
the
it.
study.
That was yeah, you know that. But that was one of the longer trials. There was another study that was for a year, but mostly, we've done, Mridula and I have looked at 6 weeks, and for Jennifer Smart, we had a trial for a few months. So
8
usually
weeks. Yeah.
8 weeks, yeah. So usually the trials that have been done and have looked at electrophysiological changes have not been for 2 years. But there have been some that have been for a year, I think. Yeah.
Definitely not
Maybe.
for, sorry, definitely not for 2 years. I've done a small electrophysiological study with autistic kids trialing remote microphone hearing aids, but that was just, they tried it for about 2 to 3 weeks. And it was really focused on specifically whether or not that can improve their ability to hear social emotional cues in people's voices. So it's very specific. But no, you should do it.
But why
There
would
is
you want to do it over 2 years? Why 2 years, Katrine?
Because
Sorry,
it
I'm
was
curious.
obviously the optimum or the average outcome when Joanne really showed a long-lasting effect, 2.5 years, if I did understand it right.
optimal duration from our small sample size was 2 years, 5 months of use.
And that's what we clinically observe, that children often, the younger, the longer, but often only are willing to wear the devices 2 to 3 years, and then they come more and more into puberty and feel stigmatized and say, I don't need it any longer. And maybe this is a good, we have the opportunity now to follow it through for at least some children. So I would ask you all to give a last concluding remark, very short, and I have the last word then. Susan, start, please.
A concluding remark.
Yeah.
Well, I think it's wonderful to see the growing interest in auditory processing and to have our colleagues here from Africa and other countries who are keen to have ways to look at this in their children and to support their children is really heartening. Yeah. So that's my concluding remark. That and also, of course, we look at this problem in many different ways and we struggle to put it all together, but that is the puzzle that we want to wrestle with so we can do better for these children with listening difficulties.
Yes, true. Joanne.
Pretty much just echoing what Suzanne has already said. I was thank you, Katrin, for putting together such a diverse panel and letting us kind of share our research and our thoughts and our expertise from so many different angles. I'm sure that it piqued different people's interests in this group of about, I don't know, 100 and something
More than
participants.
160, but many more than 500 have already registered, so they will probably see or watch our webinar later on.
Yeah.
Yeah, thank you.
But thank you everyone for tuning in from all over the world. It's probably very late in some countries and very early in others.
Yeah. So going to Harvey, please.
Yeah, so stay tuned for more from me. The SoundScouts database of every time a test is done anywhere, the de-identified results stay on there. It's proving a really fertile data source for me to look at relationships. And as we're adding more tests and indeed questionnaires to it, indeed in a couple of weeks, it's just going to be richer and richer. And so I hope we'll be able to flesh out the relationships between all of the abilities to a greater degree with much greater numbers than has been possible. And really, it's the clinicians of the world who are using it that are making that possible. It's like continuous research. It's great. And thank you, Katrin, for putting this together.
Thank you, Harvey. And now, Amelie.
Yes, thank you all for the interesting presentations. And I think this exchange was really, really very, very good, and to learn more about the topic, and we will learn much more in the future years. Thank you very much.
And David?
So I think that my bottom line is that we've shown the hugely expansive region of the brain that's involved in speech processing and how that acts in a unique way relative to other forms of auditory stimulation. And as I think Katrin mentioned, I think it's just very pleasing to see an objective measure that shows such a strong influence of listening difficulties, which would silence some critics who say that we're making this whole area up and that there's no such thing.
Okay, Ridula.
That was a good one, David. I think I would say that there is been a lot of change in our perspective. It's been, up and down a little bit, but it is reassuring, as Suzanne said, to hear other countries taking it up where it's been, and probably what we really now need to do is be a little more collective in our approach. So seminars such as these are very useful. And it's good to hear, Javi, that you're collecting all this data to make sense of some of these tests and what results we can glean from there. There was a question about LMICs. So I think rather than reinventing the wheel, we have the responsibility, having done this and learned our lessons, good, bad, and ugly, that we share them so that people who are getting into the fields now don't have to make the same mistakes. And collectively, we can actually also look at how to progress this field, because the kids are there, whether we call them APD, listening difficulty, it doesn't matter. The kids are there, they've got a concern. Teachers are not as well equipped because the training is not there. So it's our responsibility. APD is our responsibility. We need to do something.
Okay, and this brings me to my last remarks. The first one is we are not anymore so far distant from each other in our approaches and our understanding of listening difficulties in APD as we have been, I would say, 10, 15, 20 years ago. So now all the attention things make a sense, give everything, speech, auditory processing, and so on, get its place in this puzzle. And this is a wonderful outcome. And what is this webinar important for? Think it over. Speech and language and voice disorders and also auditory processing disorders or listening difficulties are not among the 375 most important disorders or conditions WHO has recognized as being important for the global burden of disease studies. They are not included. However, they impact the life or years of life of many children and adolescents, and of course also of adults and elderly people. If we really stand together in such a way, maybe we can raise more awareness for this topic. Yeah, this is my last word, and thank you all so much. The speakers, please remain for a moment, and goodbye, and thank you, nice audience, for all your constant and lively interest.